Thank you, Anil, for giving me about me a small introduction, and I hope I didn't disturb many of the delegates who are there because of this time delay. Now, you can see this PowerPoint, right? Isn't it? Is it moving?
Yes, sir. Yes, sir.
So you could see a water image that which was moving earlier. That's basically a waltz dance. And what we are going to do is also that only right now, if you don't know the concept of Push-Over syndrome and how to manage. In the sense like the patient will be literally leaning onto you, and then after that you will have a time of strengthening yourself rather than improving the situation of the patient. To begin with, these are the contents. And I'll be giving a brief introduction, then going into the anatomy, consequences, pathophysiology, and other things. Since time is an issue, I'll just try to skip at the as fast as possible, right? As we know, like the Pusher syndrome is an altered perception of body's orientation with respect to gravity, and it was described first by Patricia M. Davis way back in 1985 when she wrote that book on steps to follow. She had given certain remarks about this particular issue, what some of the stroke patients face. Now, basically, according to her, as well as based on the literature, this particular issue or the behavior is seen basically in right hemisphere damages. And right hemisphere damages causes various other things other than the contralateral hemiplegia. It causes pushing behavior or pusher syndrome. It produces other perceptual problems also like anosognosia, hemi-neglect, and in severe cases, it can also predispose for ipsilateral gaze preferences as well as rotation of the neck. These are some of the qualities of right hemisphere damage. There are more also, but I'm not going into those components like the other perceptual components also. But these are some of the important things that which everybody knows about. Now, somewhere in the late 1900s, Pedersen had told that this is not a syndrome, but it is one of the features of right hemisphere lesion. And later, okay, there were many other literatures that which had talked about this Pusher syndrome in different names. So the alternate names usually that you see in the literature are lateral pulsion, controversy pushing, then ipsilateral pushing, and also one old one that is listing phenomenon. Stein-Brunstrom, in our original book on movement therapy of hemiplegia, also had quoted about this particular issue. She mentioned that the subjects who have verticality issues, difficulty to maintain their sitting erect posture, they tend to list, they tend to fall. But whether all this tendency for falling, whether it should be considered as pushing, that we'll elaborate it later. Now, regarding this postural deviation, the issue is in the frontal plane, or in other words, it's like the coronal plane. It is not in the sagittal plane. That means the patient tends to lean, or the axis goes towards the right or left side, not forwards or backwards. And as a result, the patients will have loss of balance. And this listing issue is always a problem for not only for the patient, but also for the the therapist too, because he will have to take care of the safety issues of the patient. Okay. So pushers mainly are seen in right hemisphere damages, and particularly, or to be more specific, it is seen in case of posterior lateral thalamus region damage or injuries to those regions or its projections. The preference for these patients is basically to lean towards or to push towards affected side. And the best part is that, like, if the therapist or the clinician or maybe even the bystander, if they try to push and gain, or rather like to try to correct their posture, bring it back to the midline position, these patients will strongly resist. In fact, they vehemently will resist. They will be very comfortable even to fall towards the affected side, but they will be very apprehensive and they will be having a heavy fear of fall when you're trying to correct their posture towards the midline. And in addition to that, their weight bearing is uneven. They tend to weight bear more on the unaffected side, or the pelvis side, that which is the affected side pelvis, the weight bearing will be more. The unaffected side pelvis, the weight bearing will be very less. In addition to that, one more important feature is that these patients, they tend to keep their unaffected upper extremity abducted, and the elbow, the intermediate joint, will be extended, and they will use that not for holding any objects, but to push that particular limb and then move towards the affected side. So what will happen? That will hamper the posture itself. In turn, like, the patient will not be able to transit, or he will not be able to safely move from supine to sitting, or sitting to standing, or even for that matter, walking. Now, with regard to the prevalence, let me tell you very clearly, there are many articles and the values do vary. Some say that it is not as prevalent as what we think. The range is, you can see here, it is from 10 to 60, depending upon the literature. But personal opinion, in my clinical practice for the last 20 plus years, we don't see the pushers that often. It is like, say, for example, like, if we are seeing in a month around 40 to 50 stroke patients, if you're lucky, you might see one patient with Pusher syndrome. So that means it's very low. It is not as common as other neurological manifestations, like, say, for example, like hemi-neglect and other perceptual dysfunctions, which are common in right hemisphere lesions. And another important thing that which you have to keep in mind is that some authors describe this issue as something that which can resolve within 6 months of time, whereas others do report that no, it doesn't resolve within 6 months. In fact, it goes much beyond that, even up to 2 years, or even up to more than 2 years. So there are a lot of inconsistencies with regard to the prevalence or incidence component, as well as with regard to the prognosis part. Now, what about the background anatomy, or in other words, anatomical background? As we know, the thalamus, just earlier only I reported about the thalamus, and I told very clearly that posterior lateral lesion of the thalamus is the one that which is responsible for this, or lesions in and around that particular structure, or those fibers that which are ingressing or aggressing from the, or rather relaying in or relaying out from that particular region. If they are involved, or those territories, if they are involved, that will lead to what is known as Pusher syndrome. Now, as we know, like, thalamus is the relay nuclei, it's a relay center, it's a major junction. It is not the junction for sensory fibers alone, it is a junction for motor, it is a junction for coordination component, it's a junction for cognition. So it is a master junction like there. In fact, it's also called as the chamber of secrets. I'll come to that later. So basically, like, these information that which are being projected into the thalamus, they are interpreted, and then after that, the appropriate signals are being forwarded to various regions of the brain. Now, this posterior thalamus or posterior lateral thalamus, and also those extensions from there, they are the main concerned areas for gravity as well as for controlling the posture upright. Now, when it comes to extra thalamic structures, there are many. I'm not going much into that, but just glimpse. Cortical structures like frontal lobe is there, temporal lobe is there, precentral gyrus is there, inferior parietal lobe is there, then parietal white matter, that means the subcortical structures, and including the superior longitudinal fasciculus, that is the association fiber, the long association fiber that is spanning between the frontal as well as the occipital lobe. So naturally, like, it's a very complex connectivity that is there, and all are basically for maintenance of upright posture against the gravity. Now, coming to this component, you can see it very well, the chamber of secret. In fact, like, in an undergraduate level and all, you would have learned a little bit of all these kind of things, and many times it's so volatile because of the complexity as well as the number of nuclei it has. You have the internal intralaminar nuclei located here. Then you have the ventro-anterior, ventro-lateral, ventro-posterior, and then medial nuclei, the anterior nuclei, the pulminar. And then you can see the medial geniculate body, which is concerned with auditory. And then you can see a lateral geniculate body, which is concerned with vision. But all I'm talking about is this blue area, that is the VP area or posterior lateral, or in other words, ventral posterior as well as posterior lateral area. This is the area that is concerned with basically with the gravity related upright posturing, and also for conscious awareness about the position, that is the kinesthetic, proprioceptive, and other things. You can see very clearly that the informations are coming from the medial lemniscus. You don't need to really worry about that. That's the dorsal column. Spinal lemniscus and the trigeminal. Spinal and trigeminal, basically the pain and temperature pathways. They all go towards the ventroposterior area, and from there it will project towards the somatic sensory cortex. In addition to this area, there are fibers that which are propagating towards the superior as well as inferior parietal lobules. I'll come to that later, but those are the most important ones when it comes to the gravity-related sensing as well as for posture correction. Now, when it comes to this right brain disorder patients, Karnat in late 1900s up to early 2000s, sorry, he had done a lot of work on the radio imaging component, and he had actually sequentially studied many of the patients who were having pushers, that too with the right brain injury. And he found that there's a common area of involvement when these mappings, when they are superimposed one upon other, the central lesion overlaps is located to this posterior lateral region of the thalamus. So if you look at here, you can see very well that this is a shaded area, the central area of the damage, and that's very close to the ventricular region. Of course, what is lateral to the ventricle is the thalamus. Furthermore, lateral is the subcortical structures, that is the corpus striatum, and in that also you have the caudate nucleus, then the lentiform nucleus, the internal capsule that is separating both. Those are the structures, and then you can see the white matter and then the cortical area. You can see literally that this is the highlighted area, or the what you call as the luminescent, or in other words, more that fluorescent kind of blue color, whatever that which you see here. This is supposed to be the central core area, and that is basically the posterior lateral aspect of the thalamus. So whenever there's involvement of this, there's a high possibility that the patient will be developing Bushra syndrome. And these lesions, it may not be always in that particular area alone. It can even extend also to the adjoining structures. That's the internal capsule, the posterior tracts of the internal capsule, and then beyond that also. Now, what about the left brain disorder patients? The lesions are somewhat the similar only. There are not much of the issues between right and left. Again, the posterior lateral nucleus, that is what is involved there too. Now, what are the consequences? As mentioned earlier, this is like a dance between you and the patient, because the patient will be pushing towards you. You'll be trying to stabilize them, and then it goes on and on. As already I told in the beginning, it's like a waltz dance. And ultimately, the therapist will become more and more stronger, and the patient will never be able to, or rather, he will struggle to achieve a neutral position. So here the issue is that the concern is for us is that safety. How we will be able to make them walk, how we will be able to make them transfer from sit to stand and other things. And definitely there will be delay in the functional training. And in addition to that, hospital stay might go up, or if not, also OPD number of visits might go up, and intense therapy also is required. And in addition to that, there will be economical burden and all other issues for the family members. So it's not a problem of you and the patient alone. It also extends beyond that. Now, what are the treatment strategies available? There are many are there. We'll come to that later in the later section. But if you're using the right treatment strategy, what we're going to do is that we're going to improve the posture. You'll be able to improve the functional recovery of the patient. And we'll be able to minimize the physical demand on the therapist, which is very important. Improvise the prognosis in the sense like for a speedy recovery, enhance the safety of the patient, and of course, minimize the burden of care. Now, regarding the pathophysiology, again, keep that in mind. Our body, the inputs are coming from various sources. We know very well that the pathophysiology, or rather the physiology of the posture, the sensory system's role and everything, how they are integrated to control the posture. I am not going into that intermodal theories and this, that, and all. All I would like to say is the importance of the role of vision, kinesthetic sense, as well as the vestibule, how they weigh each other, how they interact with each other, how the environment interact with each other. Well, that I don't think it is the scope in this particular topic. All I would like to tell is that for maintenance of posture in space, you need a complex interaction or an interplay of these sensory inputs. And definitely there is an internal representation of a body in alignment with the gravitational vertical. In other words, body has an image of how to keep it against the gravity. And there is always some reference values and all those things, which always will be utilized by the nodi without your knowledge for maintaining the posture. Now, it is with respect to that only, with regard to the gravitational verticality, when I'm talking about this parietal lobes, the importance of that. That is the most important area of the brain which is concerned with that verticality with regard to gravity. In fact, it receives input from multiple locations, the vision included, but more than that, it's proprioceptive and other things which reaches that particular area. And that is the one that helps the individual to maintain upright posture against the gravity. You can see here the superior and inferior lobules, they are the most important one, and the projections from the posterior lateral nuclei, they go towards this particular region, and they are the one that is responsible for maintenance of erect posture. Then you might wonder, then what about the vision? Do they have a role in graviceptive kind of erect posturing? To be very frank, let me tell you, a patient that which is having Pusher syndrome, if you put them in a room that which is poorly lit, and you support them in a semi-reclined position, and then you give an object and ask him to identify what is the verticality of that visual stimuli, he will precisely tell what is the verticality of it. The same chap, when you make the patient erect to sitting, you can see that he will be struggling, you'll be pushing away from the normal verticality, you try to correct him, try to get him back to the neutral position, again he'll be fighting, and he will be trying his level best to fall towards the affected side. So just see, both are different. So what I'm trying to say is that the subjective visual verticality is different from subjective graviceptive or perceptual verticality. Both are different. One uses a different system, other uses another system. Maybe the inputs, the sensory components used are different. They might be same or they might be different. It doesn't matter. But ultimately, both are different aspects, or rather, they're two different circuitries. And that is why I told you this posterior nucleus. This is one area that is concerned with graviceptive sensations and the role of superior and inferior parietal lobe in that also. So that is why the patients who have right hemisphere lesion, they have a high probability. But keep that also in mind. It is not necessary that right hemisphere patients alone will be having pushers. We had seen patients where, including acome aneurysms and other things, where there was extension of or damage to the temporal and frontotemporal regions also had pushers. What I am trying to say is that the possibilities are higher when it comes to the right hemispheric, and that too involving the posterior nucleus, posterior lateral nucleus of thalamus or its extensions. So again, you can see here very well that right brain damage, that's a distal body-centric representation of space. And as a result, what happens, there's an ipsilateral mislocation of the spatial axis related to body. That means if a person is having a right side damage, the body's centrical representation, egocentric representation or orientation will be shifted to the ipsilateral, same side where the injury is there. But the problem is that there's a displacement of that orientation to the ipsilateral side. But the problem is that the patient cannot stay there like that. He would like to move away from that. He doesn't like to. There's a kind of a fear factor there, which makes them lean to the other side. They don't want to be in that particular position. In fact, few studies already had commented also that the axis will be deviated by 18 degrees to the ipsilateral direction. 18 degrees. So you can see that it's already displayed. The patient, if there's a conflict there, he can't stay in that particular position. He'll be compelled, he'll be forcing himself to move away from that particular position. That's the reason why he uses his upper extremity or the lower extremity to push and move away from that particular attitude. And that is why invariably the plane, or in other words, the axis moves to the affected side, or they tend to fall towards the affected side. So there is a misorientation there, there is a misrepresentation there, and as a result, that creates a conflict in the bargain. What the patient does is that he will be compelled, or he'll be forcing himself to correct that particular issue. And then as a result, they will be leaning or listing towards the other side. As earlier mentioned, the graviceptive, the receptors anatomically as well as functionally, they are different. Now, if you look at very clearly, see, for example, if there is a lesion of the vestibular cortex, if there's a damage to the vestibular cortex, which is there in the insular region, what will happen is that the subjects, they will have a tilted attitude of visual vertical will be tilted. But at the same time, though it is tilted, they will not be having any kind of heavy apprehension, and that pushing phenomenon won't be there. Though they are tilted, the pushing nature won't be there. On the contrary, if there is involvement of the posterior lateral thalamic region, then there will be controversy pushing. It is not just tilting alone, they tend to push also. You can see here, patients with controversy pushing show a normal perception of visual vertigo, but with a severe tilt of perceived body verticality in the frontal plane. Now, again, these are again theoretical one only. All I would like to say is that there is a error, or there is a damage to the topographical organization of our body image, or rather not image per se, the axis, which is concerned with upright posture with regard to the gravity. So when there is an error with that, what will happen is that the entire, that's a necessary, all these things will have, affect the personal as well as extra personal spaces. So that's it about this one. You can see that again, it's a continuation only. All I would like to say is that there's an altered egocentric body organized or orientation, and as a result, the patient will be falling. Now, one small thing what I would like to tell is that even neglect patients also have altered egocentric body center disorientation is there. But then one thing you have to keep in mind is that in these patients, that the listing or the lean is towards which side? It is not towards the affected side. They tend to lean towards the lesional side or the unaffected side. The unaffected side they will be leaning, whereas on the contrary, in case of neglect, in case of Pusher syndrome, they tend to lean towards the affected side. Even the neck rotation also will be different. And the most important thing, as mentioned earlier, is that patient, they don't align with their body COG with their perceived postural vertical. In fact, they will fight against it. And as a result, they will tend to list to the affected side. So these are the points that I would like to talk about the pathophysiology. All you have to remember is that there are graviceptive receptors are there. The circuitry is concerned with that. If there's a damage, then that leads to what is known as pushing behavior. The altered egocentric orientation is disrupt. The altered egocentric, this one is there both in neglect as well as in case of in pushers. But one thing is that the pushing nature as well as the tendency to fall to affected side is only seen in pusher syndrome. Now, outcome measures, I don't want to go into that. There are 3 or 4 outcome measures that's available, but none of them are gold standards. When you say gold standard, it should be reliable, it should be valid, and it should be able to even identify even the minute, or I won't say minute, at least the nominal changes, whatever that which happens with regard to the intervention or with regard to the management. So you don't have any gold standard diagnostic tool. Whatever that is used are the main are basically the you can see the scale of controversy pushing developed by again Karnath, and then after that a modified version is also available. Then Burke lateral Persian scale is there. Then there's a 4-point and all those things. I'm not going into those aspects now. Anyway, the oldest one was developed by Karnath way back in late 1900s and early 2000, and it assesses the patient sitting and standing. And the 3 components that which assess is the spontaneous body posture, how they are sitting and standing. Then do they use the upper extremity for pushing, and how bad they are pushing, the resistance to passive correction. So the maximum score is 6, cutoff is 0, sensitivity is 64.7, it is low, specificity is good. And this is how the scale is. Modified is, they had added some transition sources, score has gone up, and a cutoff is less than or 3. So that's how it is. And Burke's lateral Persian scale is also there. That is also another one, which takes even the transitions, including ambulation, into account. It's a 17 max score test items, of which 1 component has up to 4. The remaining are all 3. So that's only just 17. And again here, if the patient is having no pushers behavior, it is 0. But if it is anything above 2 or equal to 2, then yes, they might be having pushes mild toward moderate or severe. Now, I don't want to go again into this comparison. All the tools are being used. Newer tools are also few are available right now, and some of them, the psychometric properties have been published recently in 2019 also. Now, what are the findings? Again, you can see spontaneous. Karnath only had talked about this spontaneous body posturing, pushing nature, the resistance, and everything. Based on that, only he developed that particular tool. And there is a tilt of longitudinal body axis towards the paretic side. And you can see three intensities are there: severe pushing with falls, severe pushing but without falls, and mild amount of pushing without falls. There's a categorization based on the intensity. Pedersen also had done additional points. He said that very clearly that pushing severity differs from patient to patient. And then another important thing that which he mentioned was that about the process of improvement, or when when the remission is happening, first to disappear is the pushing nature in supine, and then followed by sitting, and then finally by standing. Now, the interventional strategies, let me tell you very clearly, the strategies are not many. It is not that like there are so many strategies available, but to pile it up together, as per this Karnath as well as Pazzi and Pedersen and other things, you can see it very clearly that the most important thing is to reassure them and also tell them what is wrong with them, what kind of issue is there with them. So you have to make them realize that, yes, there is an issue with the perception of erect positioning. And also you should provide an environment that which facilitates to regain the posture. So visual expression is very important. When you're sitting with the patient, you can always ask, am I sitting erect? Am I tilted to this direction or that direction? Can you bring it towards the same position as mine? You can ask the relations also between you and me. How far are from me from you, or what's the distance from the wall? Like that. Are you moving away from wall? Are you coming closer towards the wall? All these kind of things you can ask. You should always ensure that the patient is exploring the environment, and there should be visual feedback units also available. And room should have also enough of vertical structures, whether it's a door frames or windows or panels or shelves or whatever it is. Like there should be vertical structures, so that we can ask the patient to reorient them towards that particular vertical structure. So that's it about it. And then eventually you should promote the activities in those positions. Same like that here also, the Pazzi, based on the clinical observation, he also had mentioned that there's a need to correct their posture. Also, there is a need to re-establish the patient's internal referencing system. And he also mentioned also the role or the importance of extending the paretic length. Usually the paretic leg will be bent like that. So there's a need to extend more weight bearing. Loading should happen through this one, so that the tendency of them to lean or list towards the affected side can be minimized. And another important thing that which Pazzi had told was about the manual guidance, how we can guide them. And that's it. Otherwise, the components are same. Now, with regard to the strategies, like commonly that is followed in various centers as well as based on the literature, there are many things. One, you have to ensure that these exercises are done on sitting on a firm ground. Second thing is that when you're sitting, when a patient is being made to sit as well as stand, ensure that the feet is strong, it's supported well and on the ground. Mirrors are good, and even you can use a vertical tape on a mirror. Even clothes with a vertical line, a prominent vertical line, a fluorescent kind of, which catches the attention of the patient, that will be even better. And for that, basically that is ensure to get that vertical reference for the patient from the environment, so that he can try to, based on the visual input, he can try to regain back its verticality. You can use the ball, you can use exercise ball and other things to refrain, or in other words, prevent the patient from pushing or trying to push away from the bed or wherever the supporting surface the patient is sitting. Tactile stimulus can be used as a cue. It can help the patient you can also guide them. It will help as a reference. And this is one important thing that I would like to talk about. Sideline position is also been recommended by some of the researchers. Now, what are the goals ultimately? Basically, you should be able to re-establish the normal posture. You should prevent the pushing. For that matter, the therapist can sit on the paretic side. This is as per the literature. I'll come to that later. Then again, here you will be asking the patient not to push, not to pull or something like that. And then after that, the paratic arm should be placed in such a way that it is not used for pushing purpose. Preferably, it should be kept in the front position, right over the lap of the patient with the elbow bent, because extending the elbow, they might again push it. Supination is better over pronation, because in a supinated position, the tendency for pushing will be less, like that. Even a gym ball or an exercise ball kept, on the non-involved side, and then asking the patient to keep the unaffected limb over that ball is also a good method of minimizing the pushing tendency. That means what I'm trying to say is that the arm is raised upwards, the tendency for push is less. But there's no guarantee they cannot push it, because even exercise ball also we had seen the patient pushing with that also. Anyway, these are some of the important points that we should like to share. Placing the pushing arm in the air, then watching the position of the leg. If he's unduly abducting or extending the knee, I'm talking about the non-affected limb, he might again push. So it's not that the push happens from the upper extremity alone, it can happen from the lower, and particularly it's even more profound when you make the patient stand, the use of leg for pushing. So these are some of the important points which are there in the recent advance, but they are again not very specific, or rather it's not giving much results. We know that Lokomat as well as these assistive devices, robotic devices are being used left, right, center for stroke rehabilitation, for better weight bearing, also for a better kinematic and kinetic training for the patient. So in a predefined trajectory, the patient will be able to walk on the treadmill, and it is based on the task-oriented approach. It's an active part as long as the patient is active, truly active, understand until he is just on the harness, just hanging on to the harness. Anyway, so that is the point that we have to keep in mind. Fear of fall anyway will be less if the patient is suspended on a harness and within the parallel bars or within the treadmill. And it allows also the patient to maintain the upright posture, weight bearing, and also it will provide, these kind of devices will provide also somatosensory cueing, a stereotype somatosensory cueing will be there when you make the patient walk with Lokomat or similar devices. And it enhances also, it's basically based on implicit learning process. Now, computer-based, virtual reality and other things are also nowadays becoming very common in rehabilitation. It's into Y as well as equivalent kind of units, balance monitors, as well as posturography units also can be used, because that will provide information about the position of the body in space, the center of pressure, and you can teach the patient how to move away from the affected side, so that the center of pressure will move more and more close towards the midline, and eventually even towards unaffected side, so that the posture becomes better. So one good thing is that it will, active participation is required. Patient's attentions also will be better. And that's a definite goal the patient wants to, or rather he's focused towards a goal and he needs to attain that particular thing. So you can see here also all these various gadgets that are used for improving the posture, particularly virtual reality, as well as balance performance unit, as well as mats like that. Now, body support system, I don't want to further discuss because it's already been told under that, RAGT as well as under the Lokomat and everything. Anyway, it all helps for lateral support. It helps. It also, you can see here the patient can be made even to walk laterally also. Weight bearing will be better, and also the paratic limb extension will be better. Abduction too. So that's all about this pusher syndrome, whatever strategies that is out there. Now, I would like to introduce something altogether different. As already told you, we had a lot of issues in handling the pushers based on the the evidences as well as the literatures, whatever that was there. We could see that some of the patients are vehemently against the correction. Whatever strategies you do also, they will not agree. And it was taking a hell lot of time, in the sense like basically a rehab, the active rehab was getting delayed unnecessarily. The patient was just simply slouching and falling. You won't even realize that these people are happy to fall towards the affected side. But at the same time, any corrections that which we try to do, like by asking the patient to lean towards the good side, you should see the apprehension level in them. So considering all these things, I've decided that there's a need to change the strategy. So way back in 2010 onwards, I started working upon a new strategy that is called as the overcorrection strategy. Of course, it won't be there in any of the texts or any of these articles. And it is not that it is only my concept alone. I've taken the good part of other existing strategies also, and I've incorporated that along with the overcorrection strategy. Now, what are those things basically? The highlights I'll tell you. It basically emphasizes on overcorrection with guidance as well as instruction. And this program basically emphasizes on, it is a distinct program that is away from the usual one where the earlier one was asking the patient to move the COG towards the non-paretic side or towards a vertical orientation. So this is a distinct program. I'll come to that as it goes. And here, the first and foremost thing is that a clear and concise explanation is required, not only the patient, but to the patient party too, because all are basically in this particular loop of rehabilitation. Then another important thing is that you have to advise also and encourage the patient to make them lie down, side lying on the unaffected side for as much time as possible. This is the first level. Discourage the patient from lying on the affected side. The tendency is other way around. That is, they tend to lie on the affected side. They might lean or they might just turn or they might even incline towards the affected side when they are in supine or sideline position. So encourage them to lie down on their unaffected side as much as possible. And the next one should be, you should acclimatize the patient in a sidewise manner. Encourage the patient to come to a side propped up on the elbow position. And then after that, you have to give some, preparatory task of basically asking the patient to prop again up and down in a very small range in that particular position itself. That means from the sideline position, coming to a slight amount of prop down elbow like that, so that they will learn to slowly control their trunk or the torso, upper torso in the sideline position. After that, you have to provide reaching out activities. It can be given for both affected and unaffected upper extremity. Say like the affected upper extremity has a power of say like around fair towards good. The leg, even if the leg is more involved, upper extremity is relatively spared. You please ensure that use that for reach out activities. But one important thing is that the reach out should be towards the unaffected side. The direction of reach out should be always towards the unaffected side. And dissuade also the patient from using pushing habits, as well as encourage them to look towards the unaffected side, turn towards the unaffected side, reach towards the unaffected side. And this acclimatization or progressive, transference from the side to sitting should continue even up to standing. The same activities will be continuing, but the intensity, the pace, and all those things, definitely they are going to become more as it moves from one position to other. So you can see here, encourage the patient, all these reach out activities and even trunk movement activities also. The trunk movement again should be towards the direction of the unaffected side, leaning towards the unaffected side. And later part, once the control becomes better, then you can initiate movements closer to the midline and towards the affected side. So that means the overcorrection that we are doing in the beginning. And once the trunk control becomes better, then gradually move towards the midline and even beyond. So you can see here, manual guidance is very important. This is the gist of things that which I would like to tell. The positioning of the patient's head, neck, trunk, therapist's hand, using cues, proper instruction, guidance by the therapist, literally like minimal contact. And by the way, let me tell you very clearly, the conventional technique says that the therapist should sit on the affected side and then start pushing. Here, you should not touch that particular side. The moment the hand comes and lands on the shoulder of the affected side, you slowly start leaning towards you. Like a magnet, you will be attracted. So minimal amount of contact will be there on the affected side. Even if you want to guide also, please ensure that minimal contact is there. And then after that, navigate through various postures, from side to sitting to standing, and eventually towards walking. So this is how it is done. And as a preparation for walking, you have to give that weight shifts. Again, encourage more of weight shift towards a non-involved side. And later part, once you know that the control is better, then yes, work out towards midline and then eventually towards affected side. So there's no question of you having a tug of war with the patient. Now, this particular strategy has worked wonders on the patient. In fact, those patients that which are having mild to moderate kind of pushers, I could manage them within 2 to 3 weeks. And that's how it was. Okay, so that's all. So you can see here, these are some, I couldn't take the videos now with all this technical scratch. I don't want to venture into also. That's it. You can see here. You can see here, basically, sideline position has to be, ensured. The model is my student only, so I have not used the patient because of the COVID issue. You can see here the reach out activities being performed in the proper position, and avoid as much as possible even the head tilt towards the affected side. The tilt should be towards down, all towards the non-involved side. So that means from the midline to this area, which will be the area where you're going to give all the tasks or the activities. You can see here sideline position, a side sitting with the leg out, then proper sitting, again reach out activities. Then you can see different plane source. It's not necessary that it should be in a forward. In fact, I'll tell you, pushers also have a tendency to fall back and sideways to the affected side as well as backwards. So you have to ensure that they lean forwards and towards the non-affected or the non-uninvolved side. So you can see all these activities. And you can see also here, hand is kept by the side loosely hanging, or you can keep it over across the chest. So you can see that this is another method, reach out activities. So you can see here, in case the question might happen, what if the upper extremity is paretic? No harm, no problem. You can use the uninvolved upper extremity for reach outs, or else why not even the torso you can use it. The head, you can ask the patient to come and touch and then go back a short distance. But throughout the maneuver, throughout the technique, especially in the early phases, ensure that he's always sitting with certain amount of tilt towards the unaffected side, because as already told you, this is an overcorrection strategy which is not there in any of the textbooks. You can see here midline activity, then going towards even the other side and then coming back to neutral. You can see here all these activities, and now you can see my manual guidance and a little bit of touch. You can see that my hand is there behind only, not touching the shoulders. It's asked to get up towards the non-involved side, and that's how the guidance is done. So basically, normal stroke patients, you'll be asking the patient to gain more weight or put more weight on the affected side. But in this scenario, because of this overcorrection and the nasty nature of this pusher's behavior, it goes to this. I mean, you have to use this unaffected limb. So that's it. And then eventually you can see that standing and also activities like marching in place and all. Again, you can see the listing also. So that's it about that. And to wind up, I'll just show you a small video. This is a patient that which was treated in Bombay. I don't want to disclose the name of the hospital. A good surgeon had treated him, but then nearly post-surgical, it was an ACOM aneurysm, and then there was some extension of bleed and damage. Also, it was involving the temporal as well as the frontal regions. And he had very severe pushers. I will say that he was continuously falling towards the affected side line. And then he was brought on a trolley after 2 months after the Bombay rehabilitation. And then he was brought to my department. And then after that, 2 months of rigorous treatment was done in the way that which I told you, overcorrection. Meanwhile, we are even giving exercise for upper extremity and lower extremity, paretic upper extremity. It's not that we are neglecting that. I'm only talking about pushers, how to overcome. So finally, we could manage that one. And then within 2 months, the subject was able to walk unsupported. And this is all I'm talking about pre-COVID time, somewhere around 2019 end. Okay. So then after that, he left. And then, of course, during the COVID time, he never came to the department. That was maybe your luck also. Just few days back, he came to the department, just visit the consultant. And that time he just came to the department also. You can see how he walks. So that's all about Fox. He has still slight amount of balance issue, but according to the bystanders, there are no issues with falls. Only thing is slight balance issues are there. So good that he came to the department. So we are giving him little more balance exercises and everything. But control wise, the walking speed wise and all is much better than what it was, and that's how it was. Okay. So that's it. If any queries are there, may ask. Sorry for delaying the whole thing.